Hi, good evening, everyone, and welcome to Rockville's chapter meeting. As we like to say, welcome to the Rock. Special attention to my Vice President, Ariel Hester, for logging in. Also, my Treasurer, Mr. Marcus Washington. We also have our Membership Director, Miss Irene, that's here. This is our first and hopefully only, and Joe Housey, our Secretary, our first and only, hopefully, virtual meeting. We do like to meet face to face. It gives us a better aesthetic. Although we're spread out a bit here in Rockville, we do like to get together. It makes our meetings go a bit better. However, COVID-19 has disrupted our industry quite a bit. It's disrupted our lives a bit. So we're happy to have the opportunity to meet. Excuse me. So we're happy to have the opportunity to meet, to even have this meeting. As you all know, I also serve on the National Advisory Board for PAHCOM. Today, our listserv was rife with questions about telemedicine, billing, and coding. I was lucky enough to be interviewed by Terry Fletcher for PAHCOM's podcast a little bit earlier in the year. We got along like a house of fire. Terry is what I like to call wisdom goddess. She has a bunch of certifications, and we are so very happy to have been able to make a connection with her, where I reached out to her and said, hey, Terry, can you do me this big gimme for my chapter? And her answer was yes. And she's worked with me to get this up and running today. I'm going to give you her formal greeting. We had a couple of more attendees that we were waiting for, but we're going to go ahead and get started in the interest of time. Ms. Terry Fletcher is a healthcare coding and reimbursement consultant, educator, and auditor based in California with over 30 years of industry experience. Ms. Fletcher is an editorial board member for ICD-10monitor.com, a coding educator for McVeigh Seminars, MGMA, AAPC, AHIMA, ICD-10 Monitor, NSCHBC, MedLearn Media, MMI, and her own company, Terry Fletcher Consulting Incorporated. She's taught over 100 specialty coding seminars and webinars every year. Terry is also a CDI, ICD-10 CM, and CPT coding auditor for many medical practices and hospitals around the country. She holds a bachelor's degree in economics, multiple certifications, and proficiencies in CPT and ICD-10 CM coding. Her coding specialties include cardiology, peripheral cardiology, gastroenterology, orthopedics, general surgery, interventional radiology, practice management, E&M auditing, and telehealth services. We can also listen to Terry every Tuesday discussing the business of medicine as it relates to coding and reimbursement on her weekly Codecast podcast. That's CODECAST podcast, available on all downloadable platforms. So we should definitely be listening to Terry's podcast for these golden nuggets that she kind of drops on you, and it changes the way that you view what you've been doing for many years. Terry, are you there?
I am here.
Thank you so much, Terry, for pitching in and being such a good sport with us trying to get this up and running. I appreciate your time.
You bet. I appreciate being part of your chapter, and hopefully we'll give them some good information today. We are, just so everybody on the air knows, we kind of put this together a little bit makeshift, so we're hoping that the technical difficulties will not back us up here. Just so you know, the couple of different virtual sites today crashed. So we are lucky we're doing this in the evening. This morning, 2 of the 4 I listened into and 1 I taught decided to just crash because it was overload with virtual meetings. So we got lucky today. So let's see if we can get this started. Okay. Oh, good. It's giving me control. Now you can hear me okay? Just want to make sure. I know, Cola, you probably muted yourself, but could you just unmute for a second and make sure you can hear me clearly?
I'm good. I can hear you very clearly.
Okay, terrific. Okay, we're going to go ahead and get started. Everybody, you are in a mute-only mode, but we just want to make sure that we will have an opportunity for questions later. There'll be some, there's a chat box at the bottom right. And so we'll go ahead and put those in there, and we will answer them at the end, because I know everybody's going to have some questions. What I do ask, though, because we've been dealing this for the last 3 to 4 days, and every single day is something different from the government, because what happens is they will put out a mandate, a directive, and those are two different things. One thing means you have to do it, and the directive means we'd like you to do it. And then they change it on us, or they update it. And so I can't tell you how many times I have reworked and retweaked and redone my PowerPoint. And so as of today, 3/18, it is current, but it could be updated again tomorrow. So just make sure you're keeping a lookout for all of those things. And telemedicine and telehealth, as we're saying here in the disclaimer, just so you know, it is in the formative stages for most offices. I've been trying to get clients on board with Telemedicine Services, probably for the last 4 to 5 years, and most physicians don't want to hear about it. And then today they're like, okay, how do I do this? So there's a lot of information that we're going to really talk about, making sure that you are accurate and not coding misinformation, and making sure that you're not reporting information or services that can't get paid for. And then we also want to make sure you know what the patient's out-of-pocket expectation is going to be as well. The other thing, be mindful of, when this telemedicine, I should say, explosion came out within the last, I would say, 6 days, it really was for the coronavirus pandemic. So they were very reactive on what you could and couldn't code for based on those diagnoses, the potential that the patient was exposed, the possibility, and there's difference, possibility they were exposed, then the exposure, then the sign or symptoms, and then the fact that they actually do or don't have the disease was where they were going with that. But because now we have patients in 65 and older under Medicare that are nervous about going into a physician's practice, and because many states and cities around the country have said you're in basic lockdown and self-quarantine, that we don't want you going to the office, even if it's not COVID related, then the next day, of course, they remove some of those restrictions. And then even today, we got another update, and I was able to include it in your material. So there might be another update tomorrow, who knows, but we just know that this is what we have as of today, and hopefully this will be helpful to you. I know there's going to be a lot of questions on commercial plans as well. Towards the end, I will comment on what you're going to be dealing with commercial plans. Coley and I had an opportunity just to talk briefly before the webinar, and there was even a specific one to Blue Cross Blue Shield. I've had some specific information to HealthNet. We've had all kinds of state-specific and payer-specific guidelines as well, but we're going to caution you on that, because what they tend to say now doesn't need necessarily equal reimbursement later. So we just want to make sure you're understanding that what you have in writing, what you have in front of you, what you can use to support your services is how you're going to be able to fight any denials or any issues later on trying to get your money. Okay, so we're going to try and give you as much information as we can, and here we go. So first of all, what is telemedicine? So telehealth and telemedicine. Telehealth is the use of medical information, and it's exchanged from one site to another, and it's electronic communications, trying to improve the health status of the patient, but it's not an in-person visit. So it's actually what we're calling virtual or off-site visit. And there's applications, and now you'll even see different apps for phones that you can use. And the first app you can pull up, I know there's Dixox, there's Vioxx, there's all kinds of different applications for this, and it'll say, how are you feeling? And it's like, well, I just want to know how it works. Is there any kind of, some kind of a virtual tutorial on it? And no, they just basically right away, how are you feeling? What symptoms do you have? Okay, let's get you a panel doctor. And you should know that as far as how telemedicine works and telehealth is that a lot of times when you are accessing this benefit, especially from a commercial standpoint, it means that the plan says they have the benefit, but then they give you a panel doctor, and it may not be the patient's physician that they want to see. And so just know when we talk about that later, you'll see that. So when we look at telehealth, then there's also a term, telemedicine, kind of interchangeable, but sometimes it's used to encompass a broader definition of healthcare. So telecommunication technology, video conferencing, transmission of still images other than data. We've got some e-health, patient portal, new codes that we got this year called digital services, m-health, remote monitoring, continuing medical education. We have some medical call centers now. And those are all part of the telemedicine, telehealth kind of umbrella as we go through it. So AMA took a position recently, and this was before all this kind of craziness came out. And it says, a recent news release, they were basically talking about physicians that are providing this service. And this has been the pushback that I've been getting as far as why some physicians don't want to do it. They don't feel it's as effective as the in-person visit. And I agree. In my opinion, I think an in-person visit obviously is the best thing. But you have to be able to see your patients and have to be able to access them and treat them and at least see how they're doing when they can't physically come into the office. And that's never really been an option before until now. But the AMA has been clear saying that even though we're giving you some new guidance on the revolution, basically, of telehealth and telemedicine, we expect that even though new technologies and new models of care will emerge and become forward, physicians' fundamental and ethical responsibilities do not change. I'm already seeing some physicians and some physician groups that are trying to use this to capitalize on some services that aren't warranted. And I'm probably going to be a little strict on that when we talk about it. But because physician practices are using telemedicine more commonly, there's also going to be a lot more regulation. And that's what we also want to know. What regulation that's been in place is now been relaxed. You've heard that the regulations have been, they call it relaxed. And some of them are called waived, and we'll talk about what that is. So the first terms you need to know, and if you don't get anything else out of this webinar, these are the two things I want you to know. There's something called synchronous and asynchronous telehealth. Synchronous means real-time video, online discussion. It means that there is a two-way communication with your patient and the physician or provider. It also can be a mid-level provider, anybody who can bill directly to the payer. So this is not for lower-level staff such as medical assistants, LVNs, LPNs, RNs, nothing like that. Has to be somebody who can bill directly, so qualified medical professionals. And then there's asynchronous. That means alerts and audio clips and file sharing and emails and exercise videos and things like that. So when we're looking at this information, you need to know those two terms, mainly because what's going to be covered under an office visit, let's say, is going to fall under the synchronous health, telehealth. So what this means, again, is real-time delivery of telemedicine using audio and video technologies to perform the visit. So SFT you might see, and that means that there's a store and forward data collection, which also includes possible asynchronous as well. There's some mobile health, so mHealth. Those are those smartphone apps designed to foster health and well-being. You might get an alert or text message telling you to make sure you take a walk today, alert you to healthy behaviors. Maybe there's an outbreak, kind of like you get an Amber Alert if there's something going on there. But that's kind of what that bridging the gap is there. And then things that we've always had, the remote patient monitoring and certain devices that can observe patients' health status, such as Holter monitors, event monitors, and think cardiovascular monitors that trigger things like that. So who can provide telehealth services? And I alluded about the physicians and nurse practitioners or advanced practice practitioners. Everybody, I always call them mid-levels. That's just kind of, I'm old school. But if we're talking APPs now, the advanced practice providers, nurse practitioners, physician assistants, clinical or certified nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists and social workers, they have a limited scope. So Medicare has certain things they won't pay for under telehealth and certain things they will pay for. And one of the things, keep in mind during this whole pandemic, is I really feel for the mental health community, because think about it, you're somebody who is dealing with anxiety and depression, and everybody's hoarding toilet paper, and then also you don't know when you're going to get to see your physician, and now you're told to stay at home. So we're trying to kind of bring some things to that patient population as well, as far as having a little bit of interaction with people. Registered dietitians and nutritionists don't fall into this trap of saying, oh great, now my nutritionist or dietitian can call patients and we can bill it as an office visit. No. First of all, diabetic counseling only, and it has to be supervised under an MD, and it's limited on some scope of services. The nutritionist never covered under Medicaid or anything, so don't try that. But there's also some limitations when it comes to the RD, so just know that. Okay, so traditionally, what's been happening, or what is in place, and this is called the place of service, And I want to go first traditional and then what they relaxed, because you have to know how the rules, what the rules were that were in place before you know how they were altered. So where can you render telehealth and telemedicine services? So this is called the originating site. So where does the patient have to be, and where are they located at the time the service is provided via telecommunications? So for Medicare beneficiaries, traditionally, and what's in place, and it's still there, means that they're outside of a metropolitan statistical area, or they're in a rural health professional shortage area, so HIPAA, and then and they're part of that rural census tract. The Health Resources and Business Administration, so HRSA, they determine that through data processing, and I've given you a link there from the datawarehouse.hrsa.gov to know how to be able to find what those geographic locations are. And then the payers typically want the place of service O2, but I have seen for the originating site that if your patient, is in an outpatient hospital, or if they're in an inpatient hospital, because some of those critical access hospital, they have their own place of service, as you can see in your CPT book, if you're looking at your a couple pages into your inside cover. And some payers want that. So make sure you know what your payers want. But the originating site basically is saying it's each calendar year. December 31st is when they sometimes add new sites, take some sites away. But they're saying that physician offices or their approved practitioners' offices, acute care hospitals, critical access hospitals, rural health clinics, SNFs, things like that. But here's where everybody was saying, well, if my patient couldn't just call in from home, why do I want to use this? Well, unfortunately, that's what Medicare was saying. Well, we understand that, but this is so that the patient doesn't have to drive 50 to 100 miles to be able to get telehealth services. We're saying that if there is an originating site that has the capability of the Synchronous audiovisual, then we're going to allow that patient just to go to the local Medicare medical facility. But now, and on the distant site, so let me kind of just give you this. So the distant site is basically where the physician is. So you have the originating site where the patient is, distant site where the physician is, and then that is who gets paid the full amount, while the originating site gets basically what they call a facility check-in fee. And I'll tell you what that is in a little bit. But if you're looking at traditional areas. But Medicaid actually has very expanded coverage on telemedicine. And so that was surprising to me. Medicaid is usually the last place you want to encourage a patient to be able to have coverage, especially under telehealth. But I'm noticing that Medicaid is much more open to the telemedicine services. And so I always take a look at those benefits as well, because it's surprisingly pretty broad. So the medical code states may select from a variety of codes in their HCPCS for that original site that identifies that patient from telemedicine services. The distant site is always going to be the O2 place of service. That's where your physician is. Okay, so some carriers have said that maybe we'll allow it to be office, but for the most part, no. And now with this new relaxed information, it's going to be to place of service too. So this is what is current as of 3/17, and this comes directly from a Medicare FAQ. And so we want to know that the Medicare put this sheet out. They put out 3 of them. AMA also put out their version of it. Everybody basically kind of sounds the same, but there's just some different language and wording. But I want to be able to expand on some of their answers for you, because you're going to have a lot of what ifs in your practice. So how does a qualified provider bill for telehealth services? Okay, so Medicare telehealth services are generally billed as if the patient had been, as if the service had been furnished in person. For Medicare telehealth services, the claim has to have the place of service O2 to indicate the billed service was furnished as a professional telehealth service from a distant site. So again, the distant site, if you go back to your definition, that's the site where the physician is at or other licensed practitioner. So where you are delivering your service. So they're saying when you use that O2 place of service, you're saying it's coming from a physician's practice, okay? That indicates where it was billed from. So as we continue with some of these burning questions, how will recently enacted legislation allow CMS to utilize Medicare telehealth and address the declared coronavirus, this COVID-19 public health emergency? Okay, so the Coronavirus Preparedness and Response Supplemental Appropriations Act, Okay, so say that 3 times fast. It was signed into law by the president on March 6th, and they didn't tell us about it until the 13th, till Friday, which I found ironic, but they said it does go back to March 6th. Includes a provision allowing the Secretary of HHS to waive certain Medicare telehealth payment requirements during the public health emergency declared by the Secretary on January 31st, 2020. And this allows beneficiaries in all areas of the country to include and receive telehealth services, including at their home. Now, remember the definition of those telehealth services. I didn't talk about a virtual check-in, and I didn't talk about the digital services. Those are telemedicine services. That's a little different, and I'll talk about that in just a second. But I wanted to just have you go back to this. This is where you, as a medical professional, okay, so whether you are an office manager on the call, whether you're a coder, a biller, a collector, front desk, anybody who's basically involved in the patient care and the administrative aspect of this, you have to read between the lines. Look what this says, and this comes right from an FAQ. It says, this act is signed into law on March 6th. It's a provision. It allows that secretary to waive during the public health emergency. It doesn't say this is forever. It says during this emergency, okay? Keep that in mind. What does this mean? What payment requirements for Medicare telehealth services are affected by the waiver? Okay, so under the waiver, limitations on where Medicare patients are eligible for telehealth is going to be removed. So remember when I gave you all of those doctor's offices, critical health centers, inpatient, outpatient hospitals, things like that. So patients outside of rural areas and patients in their homes are now eligible for telehealth services starting March 6th. So anything prior to that is not going to be covered under this telehealth benefit, or I should say the waiver of the benefit. The patient's home can be considered an originating site during this emergency, but there's not going to be any billing for the originating site, of course, because it's the patient's home. But you're going to be the distant site, the physician's practice, and you're going to bill it as an O2 place of service. Okay, so this question always comes up. I actually was amused when they actually put this on the FAQs. Why hasn't this been done before? Okay, a couple of reasons. Current telehealth law only allows Medicare to pay for practitioners for services like routine visits furnished through telehealth under certain circumstances. So, for example, the beneficiary receiving those services must generally be located in a rural area and in a medical facility. And that's where the beneficiary receives those services, and that's the eligible originating site. The beneficiary's home is generally not an eligible originating site, but under the new waiver, and you want to make sure you've written that down, 1135, that is the waiver, that's part of that bill. This will be waived during the emergency. You're going to be using that for any denials you get, because I guarantee you're going to get some denials. It's unfortunate because what the denials are going to stem from are going to be the fact that Medicare may have not, when they sent it out as a national coverage determination and emergency waiver, a lot of the MAC carriers are scrambling to get this into their system and make sure that it bypasses any edits. And so because when you send telemedicine services, and I've been doing telehealth for a long time now, you have to have the distant and originating site. It's kind of like when you do a surgery. Think about this. You submit for your surgery or a procedure and you know it was done in the hospital, and a lot of payers will wait to pay that surgery until they get the hospital charge for the facility. Similar concept. So now the MAC carrier edits within the system has to realize it's not waiting for an original site. So it's allowed to pay the distant site under the O2 policy. And that's what that waiver does. So they have to make sure it's in the system, and you want to make sure that you have that waiver number in case you have to appeal it. So this will now allow telehealth services to be provided in all settings, including the patient's home. It's going to be a little tricky in the hospital, and I'll let you know why in a little bit. The other thing I just wanted to mention here, why wasn't it done before? Also because we don't want excessive, I hate to use the word fraud. I don't like that word. I would say overutilization. How about that? So we'll switch from the F word to the O word. Overutilization happens in everything, and we don't like it. And unfortunately, I audit for Medicare, and so I see it all the time, where as soon as you give an inch of something, someone will take a mile, and they'll say, well, if I can do this, now I'm going to do this. And so otherwise the Medicare program would go broke. So if they allow this on all settings, that's not appropriate unless we're in a state of emergency or a country of emergency. And that's what that pandemic is. So what services can be provided by telehealth under the new emergency declaration? So there is a list that are normally furnished in person that may be furnished via Medicare telehealth. And I've given you a link there so you know what that is, because there's some minimal procedures as well, you know, smoking cessation, advanced care planning, things like that. Some of those things are on that list too. So I just want to make sure you're aware of that. These services are described by HIPAA codes, okay, and they're paid under the physician fee schedule. Under the emergency declaration and waivers, these services may be provided to patients by professionals, again, regardless of the location. And Medicare pays separately for other professional services that are commonly furnished remotely using telecommunication technology. One of the services is the virtual check-in, the G2012. Now that's usually furnished through communication technology, and that's a care management, one of the care management services. Let me put that in there. So you might have, I think I have a slide on this. I have to, when I go forward, but I'll just kind of mention it now. That is different. A virtual check-in is different than what I'm talking about on telehealth. What a virtual check-in is, and again, if I have another slide on this, it'll be a little bit of duplication, but that's okay. What that is that's a patient, let's say, that hasn't been seen for, let's say, 10 days to 2 weeks. And it's a patient that has frequent urinary tract infections. Well, the patient feels one coming on. Sometimes they're also brought on by stress, believe it or not. But the patient feels one coming on. They're concerned. They call the office. They speak with a nurse practitioner and say, can I get a prescription of Augmentin? That helps me. I have frequent UTIs, and I just don't need to come in. And the nurse practitioner says, absolutely, I know who you are, has an established patient. I'll call it in for you. We'll get that to you. Don't worry about it. Don't come in the office unless you feel it was, didn't work for you, and let me know how you're doing. And that's it. And that's worth about $15. And that doesn't have to be video. That can be just a phone call. So if you're not billing for those now for Medicare patients, that's a scenario. So the patient can't be seen 7 days before, and they can't be scheduled for the first available after or within 7 days after. It's basically, do they need to come in? It's a virtual check-in, and any diagnosis is appropriate. So you just have to make sure that they haven't been seen within 7 days prior to. But the nice thing about this code is you bill it as place of service 11, so it's office, and it's not under the telemedicine service. It's a virtual check-in. That's the difference. And the patient can just call. You don't have to have a video. So a couple of things there that are very helpful in that insight. Would physicians and other qualified providers be able to furnish Medicare telehealth services to beneficiaries in their home? So yes, again, some of this may sound duplicative, but I just want to make sure you have it really honed down so you understand it. So the waiver temporarily eliminates the requirement that the originating site must be a physician's office or another authorized healthcare facility that allows Medicare to pay for telehealth services. So again, in their homes or any setting, they're going to allow. So who are the qualified providers who are permitted to furnish these telehealth services under law? So I've given you a couple of lists, and you want to always make sure you're staying close to those lists because they will check. So other practitioners, such as the certified nurse anesthetist, registered dietitians, there's a scope of practice consistency there, and so make sure you're looking that up under the Medicare benefit and the rules. But that wasn't changed by the waiver. Will CMS enforce an established patient requirement? So that's something with telemedicine. I actually, when I tried to get practices on board with telemedicine and get their initial feet wet in it, what I try to do is I try to get them to start with an established patient. Because for me, telehealth was really hard to swallow. When I started investing in some telehealth companies way back in 2014, I was like, okay, this is interesting because, again, I'm old school. I like the personal touch. Even Coley said with your chapter meetings, she likes you guys being able to network and get together in person. But again, you have to kind of move with the times and offer services, not only that speak to your MIPS and NACRA, but that are best practices, that are patient benefits, and also help to keep your patients under safety. This is also one of those things. But the one thing here, when we talk about the established patient requirement, it's not going to be required as it would be if it was under normal circumstances. So it is imperative, they're saying, under this public health emergency, that patients avoid travel, and they're talking about over 65, when possible, to physicians' offices, clinics, hospitals, or other healthcare facilities where they could be at risk, or expose other people to risk. So the HHS said that they announced the policy of enforcement discretion, okay, for Medicare Telehealth Services under the waiver under the section 1135B8 of the Act. So to the extent of this waiver, it requires that the patient have a prior established relationship with a particular practitioner, but they're not, so this is how you're going to get around it. HHS is not going to conduct audits during this time to ensure that a prior relationship existed. So it still exists. What the waiver is saying is that from March 6th until whenever the HHS secretary says this is over, they won't audit you for this particular problem. Now, I got a message today from my contact when I audit that said that they are going to audit telehealth services because they can already see this is going to be a nightmare. So this is why we want to make sure you're accurate. Is any special equipment needed to furnish Medicare telehealth service under the new law? Okay, so this is where you need to be very clear, because even after I've talked to physicians, talked to practice managers, talked to coders, I'm still getting the same question, and you need to understand the rules. So currently, CMS allows for the use of telecommunications technology that have audio and video capabilities that are used for two-way, real-time, interactive communication. So for example, to the extent that many mobile computing devices have audio and video capabilities, that may be used for a two-way, real-time, interactive communication. They qualify. So what if your doctor just has a call with your patient? Does that qualify? It does not. Does it qualify for the virtual check-in if that's needed? Yes. Does it qualify for an office visit? No. So it has to have audio and video. Had a physician call me today, actually two, saying, okay, so I read all the information and I had 10 phone calls with patients. I'm like, back the train up. Did you have the video part of that? And he's like, no, my patients are older. They don't really know how to work their video or their Skype on their phone. So we just did a phone call. It's fine. I'm like, well, that was very nice of you. Consider that your contribution to the pandemic, because they're all free. You can't report it if you don't have video capabilities. And remember, this video has to have saved capabilities. That's what the audit's going to consist of. They're going to ask you for that video if you're audited. So the new waiver, again, Section 1135B of the Social Security Act, explicitly allows the Secretary to authorize use of telephones that have audio and video, and we can't say it enough, capabilities for the furnishing of Medicare telehealth services, again, during the COVID-19 emergency. Okay. In addition, effective immediately, the Office of Civil Rights will exercise enforcement discretion and waive penalties for HIPAA violations against healthcare providers that serve patients in good faith through everyday communication technologies such as FaceTime or Skype during the COVID nationwide public health emergency. And I've given you a link there that tells you about that HIPAA. I don't know if I like this waive as far as the HIPAA, because I think that could cause a lot of issues. But basically what the conversation was when they put this waiver in as far as the HIPAA, because there is a state of emergency, this is where they are allowing this, and the public health emergency. But what they're basically saying is, let's say the patient is on the call, and let's say they're on their iPhone with FaceTime, and they have people in the background that you don't know would protect their information, and they're having a call with the physician at the same time. They're going to not say that that isn't HIPAA protected, or at least they're not going to audit for that information. So they're saying that it's going to be hard to have complete HIPAA protection in these times, because you want to access the patient wants to access the physician, and it's going to be interesting. How does a qualified provider bill for telehealth services? So I can't say this enough, apparently. You bill it under the O2 Telehealth Services. And remember, telehealth is going to be your office visits, okay? So new or established patients. How much does Medicare pay for telehealth services? Okay, and I actually want to go back to this. When I say office visits, I'm not talking about the virtual visits. That's different. The check-in, I'm not talking about the new digital codes. Those are not telehealth. Those are when there's a patient portal and there's only an email from an established patient that emails back and forth to a physician. So those are different than these are, and those also have global days. They're talking about telehealth, not telemedicine. And then again, how much does Medicare pay for it? They're going to pay the same amount for the services. They usually have different rates. So now they're going to pay the same service when they're furnished via telehealth. You better believe these are temporary. I could see a lot of physicians getting very excited about the fact that they can have a phone call with the patient, don't have to see them, and say, wow, I'm still going to get my $183 for a level 5 service. And I think most of you just felt my head explode. So I think it's important that we have this benefit, and I'm really happy that the parity as far as payment is being considered here because of the fact that we're in the state of emergency. But I think we have to be also cautious with this because it could get out of hand and we don't want Medicare to go broke. Are there beneficiary out-of-pocket costs for telehealth? Okay, so we've had some information yesterday and then something that happened today at noon my time. So it says the use of telehealth does not change the out-of-pocket costs for beneficiaries with original Medicare. So their Advantage Medicare, the Medicare Advantage one's different. Beneficiaries are generally liable for their deductible and coinsurance. However, during this time, the OIG is providing flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by federal healthcare programs. So any COVID-related telehealth visits under Medicare, they're waiving the copay to the patient, and the deductible may be waived if the virus is contracted and ongoing care is needed. Okay, so that's really related to that virus. But today, now I heard the president say, and I heard this put into an act, all copays for Medicare patients over 65 that need to see the physician for a medically necessary visit for telehealth and regular in-person visits during this initial 90 days, dating back to 3/6, will be waived. They didn't say deductibles. They just said copays. Okay, so they're going to waive those. Now, I'm assuming, and I probably shouldn't, but I'm assuming that this is going to be heavily tied to COVID-19. They didn't give us diagnoses where they're waived. They said any visit can be under the telehealth, but I would think that tomorrow they may put that out there. We'll see. As we start to slow the process and so slow the spread and see certain things die down a little bit, you're going to start seeing them saying, okay, now we're going to take this back from you. So how long does the telehealth waiver last? That's a big thing. It lasts until the state of the emergency declared by the secretary ends. So when they declared it on January 31st, as soon as it ends, then it'll last. And believe me, it's going to be like a hammer coming down. So all of a sudden you'll be like, wait. Because what happens, think about this for a second. And this is something just to keep in mind as you're going through this, especially I know how many of you are either certified medical managers through PAHCOM, are administrators, or are working to that end. And I know you've probably been pulling your hair out with all of this. But when you're looking at when this will end and just kind of how this is going to go, you have to monitor this situation. Because think about this. Think for those of you that do, I know this is one of the domains in the credential. Think about those of you that do human resources and you're dealing with staffing and vacations and all that, payroll. Anytime somebody takes a 2-week vacation, this is usually why people like to have it split up. Anything you do for 2 weeks is considered a habit. Well, if we're allowed to do this for 3 months, how many patients are you thinking are going to want to come in for a visit? How many doctors are going to want to see all those patients now and be like, oh my gosh, I can take care of this over the phone, over video conferencing. This is a great time. So as much as I feel that this is absolutely important and necessary, there's going to be a big, I would say, especially in an election year, there's going to be a big backlash when this is finally like, this is now over. You can't get this now. We're now going back to the original way we set it up. And people are going to get comfortable with the fact no copays, certain things are waived, out of pockets are relaxed. And they're going to say, wait, we like not having to deal with that. So just as administrators and office managers talk about adding to your workflow process, you're going to have to deal with this. Can hospitals, nursing homes, home health agencies, or other healthcare facilities bill for telehealth? So that would be no, okay, because billing for telehealth services, it's limited to professional services. So the access hospitals can bill for their services under the CAH method too, and then so can federal rural areas. But when you're dealing with if the patient actually is in an originating site, then they're going to use a HCPCS code, the Q3014, because that's what that's there for. basically the waiver is saying this is how the patient can call in from their home. Can qualified providers let their patients know that the Medicare covers telehealth? Let's talk about that for a second. So the answer is yes, qualified providers should inform their patients that services are available via telehealth. I had a physician call me, and actually I know he was joking, but I thought this was kind of funny. He said, so can I hire a helicopter or a plane with a banner on the back that goes over the entire city saying that now I offer office visits over the phone? I'm like, you know what? I'm just firing you now as one of my clients. He goes, I'm joking. He goes, but I'm just saying, what can I do? So here, that's the funny thing though. Welcome to my world. These are the type of questions I get. And even though I think he was joking, I bet he was half joking. So this is where, and I did get one email from another practice that said, how do we inform patients? We want to let them know. So here is and I want to say the spirit of the waiver, okay, because it's not explicit, but they're careful in what they're saying. They're saying you should inform, but not initiate, okay? So again, this is where you have to read between the lines on the FAQs. You can inform, but you can't start calling patients, starting at A and saying, hey, guess what we offer? No. Put it on your website, put it out on social media, and how I would word it, and this is something that maybe PAHCOM wants to consider doing as a group too, to figure out how to word it, having some good language, but I would word something to the effect saying, patients, if you have a scheduled appointment or if you are in need of a medically necessary appointment due to illness or whatever your specialty is, please know that at this time, telehealth benefits and virtual visits are available. We can see you via video conferencing or via two-way communication, however you want to word it, and basically explain what Synchronous video is, so they don't just think it's a phone call. So you will have a share of cost, and we do need to get consent from you. And I'm going to talk about consent in a minute. But you really want to make sure that your patients are aware. So it's helpful to put it on your Facebook page, put it on your website, put it out on Instagram if you have an Instagram page, and let patients know. You can put it on, if they call your office and they get a voicemail right away. For those of you calling for an appointment, you can press 0. Also know that we have telehealth available for you if you need it, something like that. So you can inform them, but you don't want to go out and start initiating all of these visits, because talk about flagging your office for an audit, and that would not be good. Should on-site visits conducted via video or through a window in the clinic suite be reported as telehealth? No. Okay, so services should only be reported as telehealth services when the individual physician or professional providing the telehealth service is not at the same location. So there's some drive-through testing sites right now, and those are only reported with the COVID test only. So there's no drive-through telehealth. So again, how is this different from the virtual check-in, the G2012, and the e-visit? So virtual check-in pays professionals for a brief 5 to 10 minute communication that can mitigate the need for an in-person visit. Visit furnished via Medicare telehealth is treated the same as an in-person visit and billing using that code, and a place of service 02. So that shows that it was a telehealth service. The G2012, that's going to be place of service 11, like it was an office, and that's just going to be a phone call over the phone. And then an e-visit is when a beneficiary communicates, that's with the patient portal. So those are those new codes that we ended up getting for digital services this year in the 9924 series that Medicare pays terrible on, but at least they allowed payment on it. They weren't going to allow it for a while, but that is there if you're set up for a patient portal. Those are the 99421 to 9942 3 codes. Are telehealth services only limited to services related to patients with COVID-19? Well, if you heard me talk on my podcast 2 weeks ago, yes. Now, no. So the statutory provision, they broadened it in a 2-week period, flexibility without regard to the diagnosis of the patient. So this is a critical point, especially with social distancing and other strategies recommended to reduce the risk of transmission and passing this along. And so since it will prevent vulnerable beneficiaries from unnecessarily entering the healthcare facility when their needs can be met remotely. So for an example, beneficiary could use this to visit their doctor before receiving another prescription refill if they need it, because Medicare still says like all services, telehealth services still have to be reasonable and necessary under the Social Security Act 1862. And if you don't think they're going to check, you're crazy. To make sure your physicians understand that these will be audited services. They just will. I can't imagine they won't be. I've already had an alert. I'm already being told, as of July, make sure you're available because we're going to be having you audit. I got one from Meridian. I got one from Novitas. And I just got an alert from Blue Cross Blue Shield Arkansas. And, okay, Trailblazers. Okay, so apparently they're really going to get on top of that. How do you think they're going to pay for all of the budgets that they're doing these billions of dollars? From audits. Will CMS require specific modifiers to be applied to the existing codes? They're not asking for modifiers right now, but consistent with current rules, there are 3 scenarios where modifiers are required on Medicare telehealth claims. So when you have the asynchronous store and forward technology for that demonstration project in Alaska and Hawaii, they have to use the GQ modifier. And then whenever there is a critical access hospital, that is method 2, that's the GT modifier. So when it's acute stroke for that purpose, and that's the G0 modifier. And they're doing that because there's statistical information they're trying to capture through that modifier. But right now, when you bill an office visit for the telehealth, you're just looking at the O2 place of service and no modifier. What flexibilities are available in the Medicaid program to provide care via telehealth for individuals who are quarantined or self-isolated to limit the risk of exposure? So states have broad flexibility to cover telehealth through Medicaid. So no federal approval is needed for state Medicaid programs, and find out what your state is saying that you can do. And I've given you a link there. I know here I'm located in California, and they've relaxed it to the point where everybody wants Medicaid now, which is funny. We call it CalOptima and Medi-Cal here, so it's a little bit different. But it's crazy because they're really allowing some payments to this. Okay, so now I want to look a little bit at reimbursement here. So the payment for these services, and again, across the Medicare and private and public sector, I know I want to just talk to you about that because I think that you're going to see also patients that have regular insurance as well. And it'll be hard for you to monitor the patient to see if they're actually insured. And payers also have concerns about patients seeing one dedicated provider. And a lot of the commercial plans do want the patient to have to be a established patient. So make sure you know what their contracts are saying. Because remember, the Affordable Care Act said that they had to reimburse for specific telehealth services, but they didn't say how they had to reimburse for it. So this is where it's kind of interesting where they're saying, well, we're reimbursing for it, but we're only reimbursing, let's say, something that is a remote device or something. So they can get around it as well. Medicare pays for the limited number of services, but as of February, March, they're going to expand it. And so a lot of the waivers in response to the COVID pandemic, that's really where they're kind of looking at that. So here's where we're at right now. For any condition, physicians can charge for the G2012, I knew I had a slide on this, $15 average for an established patient calling to determine if they should come in for an in-person visit. This can be for a coronavirus test or for something related to UTI, BP, blood pressure spike, anything, as long as you have a consent for that patient. Now, this one does have a signed consent. I'm assuming they're going to waive it on this one, but I haven't seen the waiver on this code. But you can bill it, and they haven't been seen in the last 7 days. Medicare stated they'll waive the copay on this service if related to COVID-19. Remember, again, this isn't telehealth. This one is a virtual check-in. And then the patients can call from their home. This is just a phone call, no video, place of service 11. The biggest caveat here is who's going to police the past 7 days? Who's going to make sure that those global days before and after are there and making sure that consents are signed? The digital online evaluation and management services, new in 2020, those are the 99421 to 423. Again, remember, those are for patients that need assessment, management, and have evaluation through portal. That's not somebody that you're going to do through a video conferencing. And so these are currently at Medicare under a non-covered status. I checked today, and it's still non-covered. They're reviewing to address this issue, but right now, if you try to bill this to Medicare, they won't pay for it. Now, will a lot of other payers pay for this? I haven't had too many problems getting this paid because they're very new in the last couple of months, except for Blue Cross Blue Shield. Blue Cross Blue Shield, they do their own thing, as you know. Can you bill an office visit? Slide 39, under the Telehealth Services when the geographic location met. Yes, okay, that's what I've been saying the whole thing. I just want to make sure you have the slide. Using the O2 place of service for telemedicine would have to be imposed. That shows non-face-to-face service with the patient, no face-to-face. It's important that these visits are patient-initiated, so you're not abusing the system with physicians sending out a blast email, call me and we can see you. But do let your patients know that if there's a need, you're available, and they can contact your office if necessary. Even with the politics involved here and many telemedicine vendors saying that you can now provide these services no matter what, you may be taking a little bit of a chance if you are not clear on the policy and not understanding medical necessity. So I do a podcast, a couple of them right now, and one of them I talk about is the difference between medical decision-making and medical necessity. And they're two different things. Not everybody realizes that. Your physician may think they might need the service, but Medicare may think something else. And just remember, this is temporary. This is temporary. So for the office managers, administrators on the call, it's going to be up to you to really police this and keep an eye on it. Consent. I know you can wait for this slide. Okay, so as of 3/16, patient consent, is that required? It is, because you are billing for a copay and you're also billing for any service that includes money. So even if they waive the copay, they still have the copay. So patient consent is required for this service. CMS has stated in the past week, and I saw it verbally, I actually took I copied the verbal video that was on TV that said that they didn't have to have a written consent, because I've only found one document that says that we won't, and it was from the OIG saying that we won't check during this state of healthcare emergency if they have a written consent during this time period. To me, that wasn't good enough, that they're not going to check. So, they're saying, yeah, we're going to keep you on your honor during this time. But I have a problem with that. So if you can get a written or a DocuSign or any kind of consent, that would be helpful. But here's what you have to have. So for patients over 65, a practitioner can obtain the patient's verbal consent, note it in the medical record, but it has to be for each billed service. So every time the patient wants to have a virtual check-in or wants to have a telehealth office visit, you have to have a verbal consent over the phone. Now, patients are probably going to get sick of you asking them, and I know that's a tough requirement there, but if they want the service, hopefully they'll understand the relaxed restrictions are temporary, and it really means that Medicare is saying, look, we're giving you a big opening here to be able to see your doctor, and we're paying exactly the same as coming into your office. But you need to also follow the rules that we do have on this, and this isn't just a free-for-all. And I agree. I absolutely agree. So make sure that you're aware that whoever gets on the call first, whoever gets on the video call, that it is clear that the patient gave consent. And if you want my opinion on this, my professional opinion, I would ask when a doctor and if there is a nurse, like a nurse or a medical assistant in the room, that they're both in there. Because a lot of times, especially the Medicare population, they could say, I never asked for this, or I didn't really see the doctor, so I don't know why I'm getting this. And you want to make sure that you have that. Medicaid has their own state requirements. I know here in California, they've already said written consent. They're not waiving that part. They said, nope, don't even want to hear it. So that you have to know what your state says. And it is based on state, and there's a lot of variation. But verbal consent's okay as long as you have it copied on that video. And make sure, I would just have somebody else in the room. So commercials and MA plans. So here's a couple of things that have been put out in the news, and this was also a press release, so I want to make sure you have it. Humana was one. They said that telemedicine costs waive for all urgent care needs for the next 90 days. Okay, so what's the definition of that? They said to help reduce the risk of infection and spread of disease, Humana is encouraging members to use the telemedicine video chat as the first line of defense for all urgent care needs. The company will waive costs for telemedicine visits for urgent care needs. How many times did they say urgent in that press release? For the next 90 days. And this came out on 3/16. So this will apply to Humana's Medicare Advantage, Medicaid, and commercial employer-sponsored plans, and is limited to in-network providers delivering synchronous virtual care via live video conferencing. So again, they're saying no phone call, it has to be live video audio. So self-insured plan sponsors will be able to opt out of the program at their discretion, which doesn't help anybody. Humana is working closely with federal agencies to understand the impacts of both telemedicine and the coronavirus test. and on the high deductible plans. And then can you report an office visit for this service? And what is their definition of urgent? And is it only related to COVID-19? So those questions right there, I've asked them and we're still waiting. They're saying anything for urgent care needs. So again, I know I hate to assume, but my assumption here is they're really relating it to the pandemic. Now, if you have a patient that, let's say, is asthmatic or COPD or has an urgent care because of the current state of this disease and this virus, then that would be considered also under urgent. So I know my clients, they've already said, under your membership, Terry, because I offer a membership on this for coding and information. They said, are you going to help us with appeals? I'm like, yeah, that's what I'm here for. So I just know my appeals process is going to blow up in the next probably 6 months because you're going to have to appeal quite a bit. HIPAA considerations. Okay, so HIPAA guidelines on this, and I kind of mentioned it before. Only authorized users should have access to the electronic patient health information, and that's what it stipulates. However, CMS, they've relaxed HIPAA compliance with regard to these services, but it's only based on the emergency at this point. So also seek legal counsel if you want to know how far this takes it. I am not an attorney. I can only interpret the law, and I would make sure that you have someone legally that can also interpret this consideration. So Skype, email, Google are not HIPAA compliant platforms under the, let me just make sure you hear me, under the original telehealth benefit. You'd have to actually get a BAA and go with like business, Skype for Business or Office 365, Google Hangouts. There's actually places you can go to get your telehealth services, and then there's different areas that you can get it from and different applications. But one thing on HIPAA now is they're allowing it during this pandemic, and again, this 90 days, I'm assuming it's going to be, they'll probably be extended, but they're going to allow Skype, email, and Google, email for the digital services. That's always been allowed as long as it's patient portal and password protected. But they're going to allow the video chat at this point as long as, and relax the HIPAA protection guidelines as long as it's during this pandemic area. So this is something that came about if you're in the Boston area, so Massachusetts, said on March 15th, he's announced that all payers must cover medically necessary telehealth services amid the pandemic. The mandate also says from the state of emergency declaration, and he gave some of the statistics on the COVID-19, and under the mandate, all commercial insurers and the Group Insurance Commission, which provides health insurance for the 460,000 state employees, will cover all telehealth services and pay the same rates as in-person services. But I got an update today, and basically they said it's only for the medically necessary telehealth services, and many payers commercially are saying they're only going to do that for COVID-19. So check commercial plans, because again, it's not everybody is interpreting these announced mandates as we have to do it for everything. Okay, and then just make sure you know the new code, and I've given you, as far as that testing, if that's something you're doing, make sure that you've gotten the update for that. I always want to make sure that you have that information. And these are some telehealth references. If you haven't implemented telehealth into your practice, these are some great companies. I love Advanced MD, eVisit's awesome. Telehealth Medicine Today, that's a great journal online to look at. They always have the updates. Diversity Health is great. I've invested in some of these companies, and they're just very helpful when it comes to implementing that in your practice, between having a great system for dealing with appointment scheduling and things like that. And they're very easy to interface with patients. Okay, so I'm going to go ahead and open it up for some questions. I did see there's some questions here. Let me see if I can pull this down. I think.
I gotcha.
Can you see the questions? I can't see them.
I'll read them out for you. So first question,
thank you.
From Diane. She says, what is correct modifier with E&M CPT code? So that was another question that came across the listserv. People are concerned about the GT modifier and the 95 modifier. So again, there's a lot of information out there. Some of it's old, some of it's new, and people are just kind of having data overload at this point.
Okay, so let me clarify. I did comment on this already, but I just want to make sure you heard it. No modifier is needed right now. That 95 modifier is not recognized by Medicare. Unless you have a commercial plan that wants it, you do not need that modifier. The GT modifier is only for critical access hospitals. And so make sure you're reading back on that slide. Let me see if I can find it, because I know I commented on it. Hold on one second. I want to make sure we have the modifier slide. Let me I find it easier that way. While I'm looking for it, you can go ahead and read the next one out.
Okay, so let's see. Lots of thank yous and yay, wisdom goddess.
That's Karen.
Absolutely, you know that's Karen. Is there a comprehensive list of telemedicine codes, multiple specialties? If so, where can we access this?
Yes, so I put this in here. So what services can be provided? That's on slide 18.
Okay.
So that is the slide that has a list of services that are furnished typically via telehealth. And let me see, I know I have modifier questions somewhere. Okay, next, is there any other one?
Let's see, you're still scrolling here.
I don't think I put a modifier in here. So no, you don't need a modifier. I thought I had one in there.
Okay, it says, in order to bill CPTs 99201 through 99215, you have to have video, question mark?
Yes.
It's a phone?
Page, yes, you have to have video and audio. So you cannot just do it through the phone. I don't know how many times I can say that over and over. You cannot just do it through the phone. You must have video. So if you have a patient, and be clear about this, that they don't know how to work their video, then you are not going to be able to bill a telehealth service for them.
Second
It
part.
can't be any clearer than that.
Absolutely not. Second part of the question, if so, does the patient need to initiate the call, or can the doctor's office do it?
The only time you could initiate a call would be to remind the patient of the visit if they're already scheduled, and to let them know now they have options. You can't basically go out and start telling everybody and start calling them saying, do you want to make an appointment? We can get you in because we have telehealth. They don't want you basically soliciting for services. That would be bad. You can put it on your website. You can put it on social media. You can, do that kind of thing, but it has to be initiated by the patient unless you have them already scheduled, and then you can give them options. You can also have it on your voicemail or video, your appointment scheduling when they call in, when they dial in. Just slide 12 is what we talked about for your modifiers. So you don't need to have it. There's only certain ones to identify, and it's only for the hospital. So go ahead.
Okay. Great. Says thanks. Also, do the video capabilities need to be both patient and doctor? You've already answered that, but that was the question.
Yeah. I don't actually understand that question. It's a two-way call. So both of the patient and the physician have to be able to see each other.
Let's see. What if only the patient is being videoed?
That doesn't make sense. Can you clarify that question? The patient is being videoed, but there's no audio conference. So you can see the patient, but they can't see the doctor. That it has to be two-way.
Right, two-way.
So yeah, also slide 32 applies to modifiers. It even is a question. What CMS requires specific modifiers to be applied? Slide 32.
Okay, let's see.
I knew I had it in there.
And lots of questions asking if they will have access to these slides.
I suppose.
Possibly.
Yeah, I'll PDF it and send it to you.
You are so amazing and so very generous with your time and talent. Looks like this is the last question. It says, what if the patient is under 65 but has Medicare due to other reasons? Will verbal consent still be allowed?
Actually glad you asked that question, because that came up finally yesterday, and I went, oh yeah, there's disability patients. Those patients are not covered for telemedicine. Only patients who unless it's just the traditional, where they go to an originating site and they're in a rural health shortage area and then you have a distance site. So they'd actually have to go to a doctor's office where they live or a hospital, but you can't do anything as far as what we've been talking about for anybody under 65. It's original Medicare, traditional Medicare, patient age. It's not for disability Medicare. So I'm glad you asked that. It has to be that Part B patient who's qualified for Medicare.
Here's another. During the waiver period, are new patient visits 99202 and 99204 covered under telehealth?
I'm told they are. 99201 to 99205. Remember, those codes don't change until next year. So for right now, I'm told that all E&M services, the 99201 to the 99215, are covered under telehealth for Medicare patients age 65 and older. So let's hope that's true for medically necessary services.
Okay, so here's one. It says, we are a paying practice and see outpatients monthly due to the type of medication. Went too far. Give me just a sec. Due to the type of medication prescribed for audit purposes, what would be necessary? We would not be seeing all your patients this way, but only those who may be ill or on lockdown.
So if the patient has an existing appointment, when they call, you're calling to verify they're coming, or an appointment reminder, you can expand now your appointment reminders to let them know you have availability via telehealth and what that includes. So that would be how I would handle that. And then let's go ahead and take one more, and then I have to head off, you guys.
Skedaddle here. Let's see. Trying to get to a good one here. More slides. We have the slides. We are a pulmonary practice and had planned to see all our patients scheduled via telehealth, but here concerned that we should not see follow-up appointments. Can you clarify? Also, we are looking to see new sleep patient referrals to us. Do you recommend doing this? So they're asking if they can see the new patients. We've already covered that part.
Okay, so pulmonary is probably the classic specialty for telemedicine, because you have patients with COPD and breathing issues, emphysema and asthma, and et cetera. Those are the patients that you don't want leaving their home right now, because it attacks the lung capacity and breathing. And so I would also see those patients via telemedicine as well. My understanding right now, as of today, is that you can see the new and established. I would not be out there basically, again, soliciting for new patients. But if you have patients that are referred to you just in the normal course, so they've seen their primary care doctor and they're now being referred to you because you have a situation where they need to be seen for possible PFTs, et cetera, then yes, so those are going to be covered under the telemedicine service.
Perfect. Terry, again, thank you so much for your time. I can speak for all of the members of the ROC. We so appreciate you and your flexibility. And again, you have earned your crown as the wisdom goddess, because, you obtain this information where we're all like panicked and whatnot. So we do appreciate your time. For all of the
No problem.
Thank you again. For all of the